So what I'm going to do today is just give you a presentation. It's something that I normally do whenever I have a patient walk into my office and say, curious, I would like some information. I think I need some help regarding my weight. I think this can benefit out of this. You know, I could get good benefit out of this. And it's something short that we can expand toward one side, toward another. And I'll get a lot of feedback from you regarding questions. I'll do the answers. And it becomes a good session. So we're going to focus on gastric sleeve, but of course if you have any questions at any point regarding any other type of weight loss surgery or in comparison to the gastric sleeve, you can do so at any moment. Please interrupt me at any point when you have any questions, all right? Because otherwise we can miss them or you can forget about it, or so just go ahead and interrupt, all right? Why weight loss surgery? And there's many, many reasons, and there's tons and tons of studies already that show this. Now, let's see. So this is from the ASMBS, which is the #1 institution in the U.S. regarding weight loss surgery. And this clearly states that weight loss surgery is the most effective long-term treatment, and also for comorbid conditions like diabetes, high blood pressure, cholesterol, etc. Now, you've probably seen a lot of papers, newspapers, magazines, etc. Well, each and one of them have published that weight loss surgery is good for you. You'll have weight loss surgery, you'll live longer. You stay with the weight you are, maybe not. So we don't have a magic ball. I don't have a magic ball in my office, right? So, doctor, well, how about if I stay with the weight? I don't know how many years you'll live. You know? Well, how about if I do surgery? Well, if you do surgery, you will have a reduction in your mortality. Each and one of us that is sitting in this room, we have a mortality risk. All right, and you can get that mortality risk by doing the questionnaire. Do you have diabetes, your age, your gender, any medical conditions, your BMI, et cetera, et cetera. You'll get a mortality risk in the next 5 or 10 years. Everybody in this room has a risk of dying. Why? Because we're all going to die. Anyway, the more medical conditions you have, the risk is higher. So the higher the BMI, the higher the weight, of course, your condition or your risk is higher. And as you bring it down, you'll live longer. If you have weight loss surgery, about 95% of your mortality risk will lower. So starting from there. I get a lot of patients that walk into my room and hear the whole explanation, this and then they go, well, yeah, doctor, but aren't these surgeries kind of risky? Mm-hmm. Right? Isn't this risky? Do people die for this? And I tell them, you know, it's people die if you stay with your weight. All right? That is riskier. All right? So having weight loss surgery is risky. It's still a procedure, it's still anesthesia, you know. But it is every risk during the surgery or after the surgery is a controlled risk. Everything is controlled. Everything can be manipulated. Everything can be addressed. The risk if you stay with your weight, no. So it's a time bomb. It's ticking. If you do something about it, you can get back on track. If you don't do anything about it, that bomb will explode at some point. Magic bomb? I don't know when. I don't know when, but it happens. So I tell patients that regarding the risks, having weight loss surgeries is very risky, isn't it? I hear people can die. Well, people die from crossing the street right here. I mean, but it's a controlled risk, as I was telling you. Let me tell you what a controlled risk is. Who grabbed the plane coming into San Antonio? All right. So you fly from where?
Montana.
From Montana. Flew out from what airport?
Billings.
And then made a stop where?
Denver.
Denver, San Antonio? Okay. So let's say you grab your flight going back is San Antonio, Denver, I assume? All right. So you're flying through American? United Airlines. All right, so United, commercial airline and everything. And plane has 239 seats, and it's a big plane. Pilots are well trained. Everything's perfect, nice and trained. So what are your chances? What are your chances to getting to Denver? Anybody thought about that? Everybody would think.
She is now.
And everybody would think. You assume, right? Diana was telling me I'm going to head out to Canada. She's already thinking she's in Canada on Monday. You know. So you're assuming all these things because they're controlled risks, because it's something that you take for granted because it's so daily, because it's so well controlled, right? That is a controlled risk. So if you think about it, you're 30,000 feet. If something happens to that plane, you're going to die, right? But it's a controlled risk. You don't even think about it because everything's controlled. Well, same is for surgery, you know? Same is for surgery because nowadays with modern medicine, you got everything controlled. You got your blood pressure controlled, you got your oxygen controlled, you got everything's controlled, your urinary output, everything. Now, surgery, for weight loss surgery for gastric sleeve, our average time, 25 minutes. So it's, of course, what's riskier? Going to Denver or going to London? London. 30,000 feet in the air for a long period of time, right? So it makes sense, right? Shorter surgery. Now, it doesn't mean that I'm not really good at it. If I'm good, I like it. I enjoy it. But I didn't take 25 minutes. I probably took an hour and 40 minutes, hour and 30 minutes. And as the years have gone by, yes, you get better. You practice makes perfect. But of course, it's not just me because I've got a whole team behind me. And the anesthesiologist gets better, and the OR nurses gets better. So everybody gets better, and everybody knows their specific part at the precise moment. Same as in the plane, right? Gears down. All right, flight control. So it's automated. You know? So you try to reduce the risk to the minimum. The shorter the OR time, the better. Now, that is a risk, yes. And I tell patients, your risk of having weight loss surgery, that. Risk of not having weight loss surgery, that. So now we've gone toward the part that we're looking into other aspects that we didn't even think about once we started to focus on weight loss surgery. But then, like major things in medicine, it works for this too. You know? So, anybody know the story of Viagra? No? Right. So Viagra is it's a medication for high blood pressure, right? But it's more specific for the pulmonary part, not the systemic part of high blood pressure. So it's for pulmonary high blood pressure. It's used mainly, or it was specifically for newborns, infants with genetic defects and everything, and it's still used today. But for older patients, they would start giving Viagra, and wow, this thing rocks, right? So then, like major things in medicine, they said, well, it's a side effect we didn't even think about, but it works for that too. Same thing for minoxidil. You know what minoxidil is? Anybody? Hair, Rogaine. Rogaine. So Rogaine, the story of Rogaine was in a pill. And they would give the pill to men and women for high blood pressure too. It's a medication, not anymore. It's not used for high blood pressure. They would give it out for high blood pressure. In clinical trials, they started to notice that men and women started to regrow hair. So, more women. So you look at the Rogaine label, the minoxidil, will say, not intended, not used for women. Women can't use things, right? There's special Rogaine for women. So anyway, so medication now is in a topical form, and you grow hair that way. It's not no longer used for high blood pressure. So anyway, we do weight loss surgery. Why? We want to attack those extra pounds. We want to just give you a better quality of life, and then all of a sudden we notice that the diabetes would go away. Patients who had insulin resistance, patients who were diabetic already, everything would get better. Why? We don't know. We don't know. But you're the experts, but we don't know. So believe me, I've been around the globe at major conferences, worldwide conferences, top-notch scientific doctors to try to explain how this works. Because it's not, here it goes, it's not the weight reduction. You may think, it's because I'm overweight. I lose the weight, diabetes go away. No, it's not, it doesn't work that way. It is totally independent, the weight factor and the diabetes factor. There was a very interesting trial by Dr. Alvarez in Brazil. Brazil has one of the top-notch centers of investigation regarding diabetes. And he was explaining to me that they started doing gastric bypass in non-obese patients. I go, because are you crazy? They're going to disappear. What are you going to do with them? Malnutrition, malnourishment. What's wrong with you guys? No? I don't know. He goes, here's a curious fact. They don't lose weight, but the diabetes goes. Amazing. So now they're doing clinical trials on non-obese patients. It's not for everybody, all right? It's a clinical trial. And they are doing gastric bypass patients. They're doing gastric bypass on these patients, and the diabetes goes into remission. So back to the question. How does it work? I still don't know. They still don't know, all right? We're on to something. We're on to something, some genes, some mechanism of interaction, stomach, pancreas, brain, hormones, food, insulin, and it's very complex. But what we do know that once you have weight loss surgery regarding, not the band, any other type of weight loss surgery, not the band, everything starts to get better and functions better independently from the weight inside. So we're close, but what we do know, it does get better. All right? So now they brought in the second name, the second last name, to the ASMBS. The ASMBS used to be called, or named, American Society for Bariatric Surgery. And then about 3 years ago, I think it was in Long Beach, I think, we got together and then they switched the name to ASMBS. Now they added metabolic, because diabetes is metabolic, high blood pressure is metabolic, because cholesterol, because all sleep apnea and all these issues are metabolic. And most of them, we do know why they go away or they get better. Some don't. We don't, like diabetes. We will in a while. but what we do know is they get better. So one thing that ASMBS did is they did it separately, the way it should be. The weight, or pounds on one side, and the metabolic, and the other issues on the other. All right? So this is a nice diagram they put together. You've probably seen it online. It's very popular because it's something official. It's something they brought up. It's something they had to go years behind on each aspect. I want to know what my migraines. Will my migraines go away? So they had to go dig into all the files and say, all right, who had weight loss surgery? All right, from you guys, who used to have migraines? Oh, who did? All right, you guys. And then from you guys that used to have migraines, did they go away after weight loss surgery? Hands up. All right. So those types of studies were carried out. Migraines, cholesterol, fatty liver, diabetes, PCOS, GERD, high blood pressure, asthma, sleep apnea, depression, etc. But here, down on the bottom, you got the most important thing. The quality of life after weight loss surgery is improved in 95% of the patients. And the mortality, what we were just talking a few minutes ago, is reduced to 90% in 5 years. So what this means is you'll be happier, living a happier life, easier life, moving around much easier, sleeping better, waking up with good night's sleep, more energy throughout the day. But the other thing is your risk of dying in the next 5 years will start to go away. All right? Questions up to here? You guys awake?
You mentioned just type 2 diabetes. Type 1 is just...
Here goes. When you have, the question is, type 2 diabetes goes away. In the vast majority of the cases, type 1 diabetes, what happens with those patients? All right, here goes. The difference is, for people who don't know, I assume you do know, the question comes from there. Type 1 diabetes, patients do not produce insulin. The cells in the pancreas is a tiny organ right here in the center of the abdomen, and produces insulin. So whenever we intake carbs or sugar, that insulin is produced, grabs that sugar, puts it into cells, and puts it to work. Type 1 patients do not produce. It's more a genetic defect, or it's an autoimmune defect. That means an autoimmune, a virus or something was, your own organism was attacking those cells, and you don't produce insulin anymore. So, type 1. Type 2 diabetes is totally different. That means you were good throughout your childhood, your young adulthood, and everything was fine, and all of a sudden you started to gain weight, and your blood sugar started to spike up. That's the vast majority of the patients that we bariatric surgeons see. The difference, type 2 diabetes, the pancreas is just not enough. It's producing and producing and producing and trying to get all those extra carbs you're getting in, but it's not enough. The pancreas gets tired, exhausted, and that small amount or X amount of insulin is not being enough. So extra sugar is running around in your bloodstream, and whenever you draw some blood, it's much higher. So, which one of the two patients, which patient do you think uses insulin, injected insulin? Well, type 1 does because they don't produce insulin. So you have to inject your own insulin. But type 2, there are some patients that get insulin dependent. Right? Why? Because you start with metformin, you start with some medications too. What the medication do is actually squeeze that pancreas, force it into making more insulin. So it can be enough, right? But it'll get to a point that if you don't do anything about it, you don't diet, you don't take care of it, that insulin is going to get tired, the pancreas is going to get tired, there's not going to be insulin, then you're going to have to require insulin. So the answer is both patients can actually need insulin at some point, but type 1 will need it right away. Now, losing weight, having weight loss surgery will make diabetes go away in type 2 patients only. In type 1, no. Why? Because it's totally independent, because the patients don't produce that insulin whatsoever. But what we do know is that type 1 diabetes, those patients will start to lower their insulin doses. So the diabetes will be easier to get under control. Type 1. But type 2, now type 2, not, I have type 2 diabetes, will it go away? Do you assure me it will go away? Well, it depends on many factors. Number 1, how long have you had diabetes? Number 2, do you take 1 medication? Do you take 2? Are you insulin dependent? If you have less than 10 years with the diabetes, about 70% of the patients will go into remission and go away. If you just take oral medication and don't inject yourself with insulin, have a higher chance. Right? So more or less, in the average, I'll go back just for a second. You'll see that diabetes, that's right here, average is about 83, and the word is resolved. But it's type 2, only type 2. Type 1, yeah, they don't produce enough insulin. Now, who's a candidate for weight loss surgery? Now, these surgeries aren't for everybody. Why? Because it's still a surgery, because it's still anesthesia, because it's still, the control risk, right? Yeah. So, if I'm going to put you at an unnecessary risk taking you to a surgery without the benefits that you're going to get out having the surgery, it's no use. I know. Diet and exercise, right? Diet and exercise, I've heard it again. Dr. Please tell me that, it's diet and exercise for some patients. But at some point, diet and exercise isn't enough. Those patients are the ones that benefit out of weight loss surgery. All right? Now, these are guidelines that we follow from the ASMBS, the International Federation for Surgery, and there's international organisms that stipulate the guidelines. All right? If you qualify for weight loss surgery, and who's had surgery with me? Raise hands. All right. So each and one of you, when we got your health history was submitted, I reviewed it. All right. I personally go over each and one of your points, and then I say, all right, you are a good candidate. Do we refuse surgery to some patients? Yes, we do. Because of risks, because you're not a candidate. But I've got the money. It's not about the money. It's not about the money. Why? Because we need to make sure that you will benefit out of what this is designed for. This is designed for to get you a really good quality of life. If you're struggling with 10 pounds, you can pay me 3 times, 5 times, 10 times as much. I won't do your surgery. I'll find somebody else, because it's not intended for that. All right. So these are the guidelines, and it's all based on the BMI. Now, BMI, body mass index. Who's heard about that term? Most of you guys know, right? So, just really quick, BMI is a calculation regarding your height and your weight. That's the formula right there. The easiest way to get it, just type it into a computer or something, all right? Google it, BMI calculator. Or go onto my website, you got the BMI calculator. All right, anyway, so if you still don't understand what the BMI ratio is, here goes. Back in the 1970s and up to the 80s, you would hear the nutritionists say, your ideal weight is, they would give you a number. That was the magic number. And that was only one number. And that number was used from your adulthood to the day you died. So nowadays, we know that we don't use that ideal weight. We use a range because there are certain things that you go through life, all right? And it's different if you're 5'5" or 5'7" when you're 25 than when you're 60. And you cannot use your ideal weight and say you're going to have to be 120 pounds or you're going to have to be 120 pounds, 120. It's not for everybody. So now we use a range. That's where the BMI came out. All right. So the normal BMI is 19 to 25. Overweight is 25 to 30. 30 to 35 obese. It works. Severe obesity is 35 to 40, and morbid obesity over 40. Now, here after 40, we've got two more classifications. Over 50 is called super obesity, and over 60 is called super obesity. I had a hard time finding names. Anyway, so who's a candidate? Here it goes. The ones in red, severe obesity, morbid obesity, right away, candidate for weight loss surgery. 30 to 35 depends any medical condition, high blood pressure, diabetes, arthritis, backaches, migraines, and any other issues. All right. So what do? I do weight loss surgery. I can do a bypass. I can do bands. I do tons of bands, including my mom's. Did I do any bands here? On anybody? Thank God. Just my mom. And I did tons of bands. Not anymore. We dropped the band from our website for almost 4 years now. And I decided to focus on one procedure that I learned in France, because this procedure I saw the future. And back in the old days, 2005, 2006, when I would say, well, you're a really good candidate for the gastric sleeve. Gastric what? Well, the gastric sleeve was approved by the FDA in June 2009. So you can imagine the hard time we had convincing patients that this was an amazing procedure. Gastric what? It's a gastric sleeve. But what is that? And then back in the old days, you would type it up in Google and nothing would show up. Nowadays, everybody's there and everything, all the information. You got tons of forums and online help and boards and a lot of stuff. But anyway, so the gastric sleeve, I saw a really good seminar. I learned the procedure in France, and then I talked to Dr. Rosenthal from the Cleveland Clinic, and because I didn't remember it was yesterday. We were in Fort Lauderdale, and we were at a seminar, and we were in a balcony overlooking the Laguna, very nice. And he goes, "I know you went to learn the procedure at France." I go, "Yeah." And he goes, and this guy was the director of bariatrics in the Cleveland Clinic, 2006, February 2006. He goes, "That will be the gold standard in weight loss surgery." I go, "How can you say that? I mean, you guys are all pro gastric bypass and all that stuff." He goes, "Just give it time." And when I started to see, not because of him, when I started to see all the benefits out of the surgery, how a quick procedure can do as much as a very intense or much aggressive procedure like a gastric bypass, do a dental switch, I said, this is the way to go. And plus, I probably take as much as doing a band and a gastric sleeve. So I said, I'll drop the band. Patients wouldn't do as well. Patients would start to regain weight, or the band would slip, move, erode, thwart the maintenance, the fees. You go, no. So I dropped the band and just focused only on the gastric sleeve. Now, the gastric sleeve, you've probably heard a lot of names: gastric sleeve, vertical sleeve hysterectomy, sleeve gastrectomy, VSG, etc. It's the same thing. Now, this is pretty much, and if you were a patient of mine, you'll probably have 5 tiny incisions in your tiny abdomen that with time they'll start to fade out and fade out and fade out. And they'll start to look, probably can't even see them in here, but one's right here, one's right here, one's right here, another one here, etc. So more than the benefits of the cosmesis, of course this looks good. It's the recovery. It's the recovery, because recovery is super fast. Recovery, patients after 2 or 3 hours after surgery, they are up and going. They are getting up to the restroom on their own and just moving around. So laparoscopic surgery is really good because recovery is super fast. That's the benefits nowadays. Just a few, about 3 or 4 days ago, I was talking to my dad. My dad's a surgeon. And we were talking about patients of mine, because they were walking the halls and say hello. And I helped my dad on surgery. We were walking the halls. And one of my patients asked me, Dr. Alvarez, can we go to the market today? I go, it's not that hot today. Sure. You can go. My dad goes, you want to go where? No, you want to go to the market? You gotta go to the market? Yeah. They had surgery yesterday? Yeah. You can do it. Yeah. And we were talking about, well, back in the old days, my dad would be in the hospital with open, traditional open surgery, gastrectomy, 7 to 10 days in the hospital, drains everywhere, catheters, NG tubes. I mean, you were barely getting out of bed, probably day 4, day 5. You know? So technology has evolved, it's applied to medicine, and this is just amazing. So I was telling my dad that, because I did, it was this specific patient, I did a hiatal hernia repair with the gastric sleeve. I go, Dad, if one of my professors looked at me right now, he'd probably kill me. You know? You did what? Hiatal hernia repair with a gastric sleeve, and then we sent them over to the market. Patients do fine, you know? But it's all because of the fast recovery during laparoscopic surgery. Now, what do you need to have weight loss surgery? Well, first of all, you need evaluation that we do personally. Through Susan, myself, we have a special online system, and we screen patients through there. After that, we check the patient out, very particular case, and we decide what he or she needs to do. Who's heard about the pre-op diet? All right, most of my bullets, of course, my patients have. So patients that are looking into the gastric sleeve or any other procedure, here, New York City, Beijing, anywhere, you'll be required to do a pre-op diet. Now that pre-op diet will vary depending on your BMI. Maybe 5 days, maybe 10 days, 7 days, 15 days, 3 weeks, 4 weeks, 5 weeks. So I've done patients that have done 8 weeks. You know? Why? Because this right here is the liver that's covering the upper part of the stomach. And the liver on a patient that has a BMI over 35 will be bigger than normal. It's called non-alcoholic fatty liver. That liver needs to come down. We need to make space. Why? Because we do this procedure laparoscopically. We don't open patients up. We need to shrink it, detox that liver, in other words, in the shortest amount of time so we can do that procedure laparoscopically. Fastest way to do it, pre-op diet. The amount of days will vary depending on the BMI. So number 1, you need the health history. Number 2, we need to screen you. Number 3, maybe a special recommendation depending on your health history. And number 4, the most feared pre-op diet. All right? It's not bad at all. It's just a 2 or 3 day. We had a hard time. Be honest. I need to see some. I mean, it's hard. It's hard. Yes, of course. It's hard. It's hard at first, maybe. I've done it. I mean, so I can, whatever I tell you, I've done it. All right, so the diet and everything, and if you stick to the patient reunion, I see a lot of my patients that are here. We're going to talk a little bit about dieting and eating after weight loss surgery. And whatever I'll tell you regarding that diet, I've done. All right, so nobody has, this happens, I've done it, all right? So I used to do that pre-op diet in January. Right? So I would do it for a week. First 2 or 3 days, it sucks. All right, it sucks. But after that, you get used to it. Now, the good thing about it, it's everything. What I mean by everything is you got carbs, you got fat, you got protein, just it's all liquid. So in other words, it's here, you know, because you're getting all your nutrients, but you get to the point that 5, 6 days you're going to munch at something, you know. So anyway, it's just those 2 or 3 days, the hardest, and then after that it's downhill. Now, most important thing here, to point out some differences, gastric sleeve versus any other procedure. This, what I'm going to tell you right here, this is what makes this procedure unique. This is what makes the procedure stand above all others. Number one, the entrance of the stomach stays untouched. All right? So you were born with that entrance. There's no band there, there's no ring, there's no obstruction there. So the entrance is free. So why don't gastric sleeve patients throw up? They're throwing up like crazy, vomiting like crazy, like lap patients are, because there's no obstruction. So number one is the entrance of the stomach. Number two, the exit of the stomach is the one you were born with. All right? So it's your own natural stomach. It's the way God intended. It's the same functions of your stomach. But taking this out of the way, you're going to be eating less. And I tell my patients when they ask me, well, how much less? Well, to make an estimate, if you're eating from a 1 to 10, a scale 1 to 10, you're eating a 10, you're going to be eating about a 3. And that's going to be about 6 months down the road, not initially, because right away, you're eating a 1. Give it up. All right? That's normal. That's the way it is. As the swollen tissue starts to go away, the capacity of stomach is there. Now, has anybody emailed me freaking out about 6 to 8 months down the road saying, Dr. Alvarez, oh my God, I can eat so much more? Because I do get those emails. And it doesn't mean you're eating more. You're eating more in comparison to the first month. You're eating a 1. Now you're eating a 3, maybe a 4. But it never, ever, ever will compare to what you were eating prior to surgery. And so you may compare yourself to what you're eating initially. You're like, damn, I probably stretched my sleeve. Man, maybe I missed something in there. Maybe my fundus is still there. Maybe I overdid it with Diet Coke. The gas. It must be the gas. The carbonated beverages. No, I'm overeating. No, it's normal. It's normal. It's expected. So that is the beauty of this procedure. There's no forebody in there. So it's a crafted sleeve. And I like to say crafted because, believe me, I take pride in each and one of the cases in crafting that precise sleeve for everybody. All right, that's our logo. All right, that's changing lives one sleeve at a time. So I see your body needs, I see the size of your stomach, I see the rest of your organs, and we craft that sleeve to your needs. Doctor, why do I see on the board that there was this gentleman that lost 50 pounds in a month? I've lost 40 in 10 months. Why? Well, There's a lot of factors. Because, number one, you didn't have to lose that much. Number two, men lose faster. Men have a lot more muscle mass, so the metabolism is faster. And, of course, the more you weigh, the faster it'll come down. But guess what? Once that gentleman starts to hit those last few pounds, oh, it struggles just like you. Exactly. So everybody's different, but that sleeve is crafted uniquely for you. All right. The other thing is that the intestine, small intestine, is not touched at all. So the nutrition, micronutrients like vitamins, minerals, everything stays untouched. So why so much fuss, Doctor, about vitamins? Why do I hear all this stuff on boards and online and everybody's taking their B12 and iron? Do I have to take iron? Do B12 a shot? Or just a multi-Flintstones? What should I do?
Yeah.
You know? So I'll bring you in with a secret. First few sleeves, Susan and I did, as I was telling you, back in the old days, there was no information out there. We started doing sleeves right away. And there was no information regarding nutrients, micronutrients, studies, anything. So we would think, same as the bands, we would think, we're not cutting intestines, so it's just a restricted procedure, so why give up vitamins? Nutrients come by regular food, that's enough. And 200, 250 cases, we never ever had an issue regarding micronutrient deficiency or anything. There was just one case reported in Germany that I saw at one of the surgical meetings, worldwide meetings in Germany, and they had a vitamin B deficiency, and I said, oh, the hell with it, I'll just give them Viagra. And then we had bigger companies started looking into marketing vitamins for bariatric patients, like Bariatric Advantage, like, is he just going to be with us this afternoon? Thorn Industries, and he's going to do it. So now it's a whole scientific world, vitamins, all right? But to tell you the truth, and I'll tell you, my mom's right here, she can testify to it. Take your multivitamin. Everybody needs vitamins. Everybody, for kids, to adulthood. Take your multivitamin, and that covers everything. You won't have an issue, all right? But then, going back to the point, not cutting the intestine, not rerouting intestines, makes a world of difference. Anybody here with a gastric bypass?
I'm sorry.
No? So gastric bypass patients, anybody know a patient with a gastric bypass? The gastric bypass patient, you can easily tell if you put four patients, yeah, and one has a gastric band, one has a gastric sleeve, one has a gastric bypass, and one has a duodenal switch. I can tell just by looking at them. But then again, that's what I do for a living, right? So the lap band patient didn't even lose weight, so that's easy to see. All right. So gastric sleeve patient looks healthy. Gastric bypass patient, pale, maybe kind of grayish skin, hair different, skin different, nails different. Now, it doesn't mean that during this extreme weight loss process with the gastric sleeve, you may not have a little hair loss. It's normal. So hair regrows. And the duodenal switch patient, they have a particular smell. All right, so it's, yes. It's very difficult for spouses. So it's very difficult because they kind of stain that smell everywhere. I mean, you jump into a car, I've jumped into a car, and literally jumped in a car with somebody, and when I smell it, I go, did you have weight loss surgery? How did you know? You know? It's a very particular smell. But of course, the procedure, the duodenal switch, is a very good procedure, don't get me wrong. It's a life-saving procedure for the particular case. All right, so, but anyway, gastric bypass patients, to the point, they look a little different. They are different. Right? Now they're going to be struggling with vitamin deficiencies, nutrients. They need some blood work every so often, anemia, marginal ulcers, and everything. Now, I tell patients, okay, maybe I need a gastric bypass, doctor. Maybe I need a gastric sleeve. Well, both will give you excellent weight loss. The only thing is, let me tell you one big difference. Gastric bypass patients, whenever you have a gastric bypass that day, that particular day, your troubles begin. That's where anemia begins. That's where vitamin deficiency begins. That's where internal hernia risks begin. That's where marginal ulcers begin, and all these issues. The day you decide to have a gastric sleeve, that day, joy appears. And once that sleeve heals, it's healed. There's no power on earth that will make it come apart. So all you have to do is take care of it those first 21 days. After that, you'll be home free. So to all this stuff, does it work? Well, we've got we've got hundreds, literally hundreds before and after pictures on our website. We've got video testimonials, we've got reviews, we've got all this stuff. But of course, you can start your own research, because of course it's better whenever you find information than me telling you or bragging you about that this procedure works.